Let's go to Toronto, where Dr. Ahmed is going to orchestrate this glaucoma program, and he'll begin with a MiGS update.
It's a pleasure and honor to guest host the VGCRGS edition of Microinvasive Glaucoma Surgery. We'll be reviewing the rationale and all the procedures now that exist in 2020 for MiGS surgeries. These are my disclosures. My name is Ahmed, and I work with many of the MiGS companies in its early development as well as current approaches in commercializing these products. In this edition, we'll cover a variety of approaches in microinvasive glaucoma surgery. We'll talk about introduction and the rationale for MiGS, iStent inject, the Hydrus microstent, trabectome and TrabX, Cahook dual blade, excimer laser trabeculostomy, Omni surgical system, abmaternal canaloplasty, endocyclophotocoagulation, Zen gel stent, and the PreserFlow microshunt. In 2020, it's still relevant to speak about why do patients still go blind from glaucoma. And there are many reasons why this still occurs despite advances in diagnostic and medical therapy. Glaucoma is still underdiagnosed, glaucoma is still improperly treated, and there's still an issue around lack of compliance and adherence. And these latter two issues are really the underpinning of why MiGS has been developed. The general approach of MiGS procedures is the premise that elevated pressure is an interventional problem, requires a variety of different interventional approaches to enhance aqueous outflow. We can divide patients up into those that are looking for medication alternatives. That's where typically the classical MiGS fits in. And those that are typically looking for low pressures, for example, in the low teens down to 12 or so, that need to achieve this safely and smoothly. And that category is what we term subconjunctival MiGS. One of the important goals of interventional therapies in glaucoma is to enhance quality of life. Of course, we need to prevent blindness, we need to enhance the aspects of the disease that can impact quality of life, but one of the important areas is also addressing treatment-related quality of life issues. We know this is a major issue with medications and traditional surgical approaches, and MiGS and subcons MiGS are designed to approach this with a more higher quality of life as well as being cost-effective. We know, of course, that topical glaucoma therapy, particularly lifelong therapy, can have a significant impact on quality of life, local and systemic side effects as well that occur that are well known on the ocular surface and conjunctiva and cornea. Compliance remains a significant problem in all parts of the world in all kinds of studies, and show that patients typically are poorly adherent over initial and also long-term topical therapy. And when patients are poorly adherent, they progress further. This has been shown through a variety of different studies. We also know that as the disease progresses and the severity advances, that the cost of glaucoma care increases as well. We must consider this when we think about the cost of MiGS as well up front. Recent data from the Collaborative Initial Glaucoma Treatment Study has also shown an association between poor adherence and visual field progression. So this is where the era of interventional glaucoma has come upon us. And MiGS is very much part of this approach and the mindset in approaching elevated pressures in an interventional manner. Some of the premises of interventional glaucoma include the lower the better, as has been shown in the Canadian glaucoma study, that even patients with mild disease progress less when pressures are kept at less than 15 millimeters of mercury. The lower the pressure, the better there is in terms of protection of progression. Addition of medications can help to reduce IOP targets. However, there are questions regarding the addition of more than 2 medications in terms of the efficacy. We also know that from the AGES study for patients with more moderate to advanced disease, that sustained low pressures can also have a better effect on the stability of visual fields, particularly when pressures are kept below 18 on average of 12. The other aspect of interventional glaucoma is earlier the better, in that the impact of our treatment can have a greater impact on a patient's lifetime, and the progression risk can be delayed further and further if we intervene earlier. And this is really the premise of interventional glaucoma: lower is better, earlier is better, safer is better, and we address adherence as well. We can think of MiGS in many different ways amongst the current glaucoma treatment paradigm, whether it's early, middle, or late in the stage of therapy. This is the premise of microinvasive glaucoma surgery, an approach that is designed to be ab interno, minimally traumatic, has efficacy, and most importantly, has a very high safety profile with a rapid recovery postoperatively. One can think of MiGS in different approaches: Schemm's canal conventional approaches, and we'll speak about this, superciliary approaches, and subconjunctival MiGS. Unfortunately, we currently have no commercial products available in the superciliary space. The CyPass device was a device that was designed to enhance aqueous within the UV scleral outflow pathway in the superciliary space. It was found to be effective. However, due to placement issues with anterior placement in certain patients of the device close to the cornea, this led to some corneal changes long-term and endothelial cell loss, and the device was pulled from the market. We look forward to more devices being placed in the space in a safer and more predictable way. So, in 2020, we have a variety of approaches that are available now commercially around the world, which we'll be speaking about in this edition. We can think about the different procedures based on their potential target pressures: phaco, MiGS, subconjunctival MiGS, and of course our most efficacious approach is trabeculectomy still. And so MiGS typically are for patients that targets are in the mid-teens, often combined with phaco, with the goal being to reduce medications while maintaining good pressure control, addressing adherence, and diurnal fluctuation. There are many different trabecular MiGS procedures we'll speak about specifically shortly, and they can be divided up in many different ways. The common features of these, of course, are to enhance aqueous outflow through the conventional pathway by bypassing the trabecular meshwork, enhancing aqueous through the Schemm's canal system and distal outflow system. One can divide up these MiGS procedures based on stenting, viscodilation, or goniotomy, and furthermore, whether this is more of a cutting or an ablation approach. Intraoperative gonioscopy is critical for adequate visualization, and it's important to adequately turn the microscope as well as turn the patient's head to obtain the adequate approach for the conventional MiGS visualization using gonioprisms. And this is very important to ensure we have an adequate view, which can't be minimized when we think about MiGS procedures, and surgeons should take time to best understand and set them up for success by again ensuring that both the patient, the surgeon, and the microscope are aligned appropriately for viewing the intraoperative angle. There are a variety of different lenses that can be used for gonioscopy. The Swan-Jacob gonioprism is a fairly straightforward procedure and does require, however, important steps and pearls in visualization to ensure compression is avoided, bleeding on the surface or in the eye are minimized, and high magnification centered and focused view is kept at all times. There are other approaches using a direct view mirror, for example, a double mirror system here, which can minimize the need to tilt the microscope while maintaining a good view into the angle. There are many questions about whether MiGS should be performed before or after phaco, and there are pros and cons between either approach. We like to do most MiGS procedures before phaco into the canal for the best view, firm eye, and less blood reflux during the procedure, although both approaches are appropriate and reasonable. We must remember with MiGS procedures in the canal, the goal is to overcome the resistance and bypass the obstructions at the level of trabecular meshwork to dilate as well and expand the canal, but we make an assumption the distal outflow system is intact. Considerations can be made in terms of how wide access we need in the canal trabecular meshwork system. Older studies have shown that 1, 2, 3 clock hours can enhance and reduce the total resistance, and after we seem to get past 4 clock hours, there's a certain plateauing effect of the resistance eliminated. This neoprene cast nicely shows the distal outflow system beyond the canal. We must consider this as we consider the approaches to enhance aqueous outflow from the proximal system into the distal system, and consider the role of the aqueous veins which are typically designed to handle a larger amount of aqueous. It's the identification of these veins and larger collector channel systems that may be helpful in placing stents or placing goniotomies or trabeculotomies in certain areas that can enhance the aqueous outflow. For example, it is found that the majority of these larger veins, which can handle a larger volume of aqueous with lower resistance, are found in the infranasal quadrant in most eyes. These can be visualized here looking at the clear fluid within a vein, as well as a trilaminar flow in the episcleral vein. One can also look at gonioscopy, pigmentation, as well as blood reflux to identify where these larger collector systems may be. We also must ask ourselves, do we still need to bleb or not to bleb? And the bleb is still the most consistent way to get pressures down to low teens to 12 and off medications. Trabeculectomy certainly is the gold standard lowering pressure. However, significant variability in wound healing as well as design of the surgery and the level of invasiveness limit the ability for this procedure to be used widely and earlier in disease. So the question is there a better and safer, more predictable and controlled way to create and maintain a bleb? And this is where the modern day blebs are differentiated with not only long-term efficacy in terms of pressure control, but minimal effect on visual acuity and refraction, a faster postoperative recovery, less visits, less interventions after surgery, with a more enhanced bleb morphology that's comfortable and lower risk for infection, and most importantly, providing for more consistent technique with reduced postoperative variability. We now see subconjunctival MiGS emerging, both the Zen gel stent and the InFocus microshunt, now called PreserFlow, are both designed to standardize modern-day bleb surgery by microshunting and microstenting. And both these devices do rely on the role of wound healing and mitomycin C, but provide a more enhanced and controlled aqueous outflow into a more posterior bleb. We must consider the differences in the fluidics between aqueous outflow through a single lumen versus the trabeculectomy flap early on postoperatively. And there are many considerations in terms of where these implants should be placed, whether they should be subtenons or supratenons, and most agree that the ideal placement is not to be stuck within tenons. We'll be covering a variety of MiGS procedures shortly and go into more detail for each approach.